some very complex and interesting case scenarios during cataract surgery. And we hope to provide you with the tools to handle some of these challenging situations. I'm Dr. Nagvekar, and I will be assisted by my colleagues. We have first on the line Dr. Raksha Dhanuka. She will be speaking on cataract surgery in the presence of compromised corneas, after which I will be speaking on small pupil and floppy iris. This will be followed by, I think, Dr. Vavekar. He will be speaking on posterior polar cataracts, and then of course we'll talk of difficult lens situations where either the capsule has got rented or where there has been zonular dialysis. I will be leaving partly during the session to attend another session where I have to give a talk, and I'll be returning back after. So without much ado, let us start with the first talk, and Raksha is going to talk to us about the compromised corneas. Thank you.
Good afternoon, friends, respected seniors, and respected dignitaries on the dais. I'm going to talk on fear of cloudy cornea, cataract in presence of endothelial dystrophy. Cloudy cornea gives a major challenge pre-operatively, intraoperatively, and post-operatively to a cataract surgeon. The major difficulty is a clear view through the cornea to the lens. Cornea endothelial dystrophies are one of the most common ocular comorbidities that we come across while seeing cataract patients, and it can be a source of frustration for both the surgeon and patient, increases the risk of intraoperative complication, and impacts the final visual outcome. There can be various causes of endothelial dysfunction, right from Fuchs endothelial corneal dystrophy, posterior polymorphous corneal dystrophy, eye syndrome, trauma, infectious endothelitis, Axenfeld Rieger's anomaly, and previous glaucoma surgery. Just a quick recap of these dystrophies. We know Fuchs is a bilateral, slowly progressive endothelial cell density. There is a decline in endothelial cell density, and there is a characteristic gutta formations. In posterior polymorphous corneal dystrophy, there is characteristic snail track appearance, and it's a non-progressive condition. Eye syndrome, among the three entities, Sandler's syndrome has corneal signs predominantly with a characteristic hammered silver appearance on slit lamp by a microscopy. Viral endothelitis can lead to cataract formation and irreversible endothelial decompensation requiring surgical intervention. Trauma, we all know, can cause endothelial damage, subsequent cataract formation, and corneal opacification. When such patients come along with cataract, the biggest question is, what is the risk of corneal decompensation? Whether we should go only with cataract surgery or it has to be combined with endothelial keratoplasty. So before deciding the type of surgery, we should be aware that what are the risk factors for corneal decompensation after cataract surgery. So patients with obvious corneal edema or bullae, increased corneal thickness, which is more than 650 microns, confluent guttete, blurred vision and glare, which is worse in the morning, and specular microscopy showing low endothelial cell count, which is less than 1,000 cells per square millimeter. There are various techniques to evaluate corneal endothelium. If we do specular microscopy, it is useful only in cases where there are fewer non-confluent and discrete guttata. But always keep in mind that early or late corneal decompensation will be there if central endothelial cell density is less than 1,000 cells per square millimeter. It is not of much use if there are numerous guttata and in presence of corneal edema. Confocal microscopy can be useful in corneal edema patients, but it is of not much use nowadays. Corneal thickness measurement, which can be done with ultrasound pachymetry or anterior segment OCT, shows that when the central corneal thickness is more than 700 microns, it is indicative of endothelial decompensation. The most important thing is that we should take an average 3 central pachymetry measurements at each visit to overcome physician and technician variability. Before finalizing the type of surgery, we should always keep in mind that cataract surgery alone will decrease endothelial cell density by 1.8 to 15%. So in a compromised endothelium, this decrease may be further accentuated, and there can be a persistent postoperative edema 4 times higher. Though triple procedure is a single procedure, the advantage is that, but there is always a possibility of higher complications. Finally, the patient's visual need and expectations should be considered, and both surgeon and patient should be mutually satisfied with the selected surgical plan. As far as the choice of surgery is concerned, when we are doing a cataract surgery alone, we can do phaco or small incision cataract surgery. In cases where there is mild endothelial compromise and patient is not healthy to tolerate a prolonged procedure. With severe corneal edema, definitely when the view is not clear, we have to either go for a triple or a staged procedure. Now, this is a video of a patient with early cataract endothelial cell loss and Fuchs corneal endothelial dystrophy. In this patient, only cataract surgery was done. So certain tips we should keep in mind while doing cataract surgery in such patients is sharp instruments should be minimally used. We should avoid contact of instruments with the corneal endothelium. Anterior chamber should be adequately maintained throughout the procedure. While doing the nucleus delivery, soft cell technique of using viscoelastic, that is a dispersive viscoelastic should be used to cover the corneal endothelium, and below it a cohesive viscoelastic should be used. For phacoemulsification, low power is always advised. Phaco chop technique and use of oscillatory handpiece is always recommended. Use of viscoelastic during phacoemulsification will be beneficial for the patient. As far as irrigating solution is concerned, Ringer's lactate is commonly used, but it is suggested that balanced salt solution should be used as it has glutathione and it gives a more physiologic environment. While implanting the IOL, the reverse soft cell technique should be used. A thorough AC wash is a must because remaining fragments can lead to raised intraocular pressure and subsequent endothelial decompensation. This is a video of a patient who had severe corneal edema and we had done triple procedure. Now as we can see here, initially the corneal epithelium was removed with the use of a cotton tip applicator. Where the view of the anterior chamber is hazy, it is recommended to use trypan blue for capsulorhexis. After completing the capsulorhexis and doing sufficient hydrodissection, the phaco technique as I advised in the earlier surgery should be maintained. At any point of time, anterior chamber should be maintained using the soft cell technique. Repeated use of viscoelastics during phacoemulsification is highly recommended. Now, once the irrigation aspiration is completed, a thorough AC wash is done and IOL is implanted. After IOL implantation, the recipient's Descemet membrane and corneal endothelium is removed and it is taken out from the main entry. Subsequent AC wash should be done so that there is no remaining viscoelastic. The pupil is myosed and donor graft tissue is inserted into the anterior chamber. There are certain points, as you must have seen, that the donor graft was scrolled upwards. That is, the endothelium should be facing outward and there should be proper orientation of the graft. Tapping on the anterior corneal epithelium will help to stabilize the graft and help in proper positioning. Once we are ensured that there is proper position, we can fill the anterior chamber with air and ensure that the graft is in position. Suturing of the main entry wound is recommended so that there is no collapse of anterior chamber. Now this is a photograph of a patient in whom we have done triple procedure using DMAC. We can see in the post-operative photograph an inferior peripheral iridotomy has been done. This is a must in a combined procedure case to avoid pupillary block. Certain important considerations: while handling such cases, if we are finding difficulty in biometry, we can always take an average K reading, or we can take keratometry from the fellow eye. 3-piece IOL is strongly considered, and in cases where the anterior chamber depth is less, we should always perform EK first. Choice of surgically, as I said, it depends on the density of cataract and surgeon's experience. Viscoelastic I already mentioned, irrigating solution I mentioned, placing a suture would be better. Post-operative, patient may need frequent steroids and hypertonic saline, and periodic follow-up is recommended. So the take-home message is, in cases of combined surgery, when CCT is greater than 640 micrometers, endothelial cells are fewer than 1000 cells per square millimeter, and there is microcystic edema, we should always go for combined surgery. Choice will depend on surgeon's experience, and when doing phaco, we should have advanced phacoparometers, phaco-chop, soft cell technique, and use of torsional phaco tip is advocated. Thank you so much.
So good afternoon once again, and today I'm going to talk on the management of small pupil and floppy iris. So, so first of all, what is IFIS? IFIS is intraoperative floppy iris syndrome. Now, we all know that, and we've all done cases of IFIS, is characterized by a highly undulating iris, which undulates a very flaccid iris, which undulates very abnormally in the presence of routine fluid currents that are seen in a normal routine phacoemulsification. And this causes the iris to prolapse out of your incisions, either via the main port or the side port. And this causes, of course, iris damage, because every time you manipulate or put instruments over there, it causes the iris to pop out even more. And this leads to intraoperative meiosis. It causes shallowing of the anterior chamber, and so on and so forth. I'll come to those details later. But normally this is caused because of systemic ingestion of alpha antagonists such as tamsulosin, which is commonly used in benign prostatic hyperplasia, also by using combinations of oxidone and oxycodone and acetaminophen, and sometimes even some of the local glaucoma drops such as clonidine and brimonidine. Now, pupillary meiosis could be due to various reasons. It could be due to senile meiosis, synechiae, trauma of surgery, by diabetes, which is by far the commonest cause of non-expansion of the pupil, uveitis, chronic meiotic therapy, and pseudoexfoliation. And intraoperative due to even minor iris trauma during performing your CCC, or even, as I will show you later, in case of femto, where there's minor iris trauma and the pupil suddenly goes small. There could be also surgical manipulation during phaco. Now, once you are down with a small pupil, your decision whether to use a pupillary expansion device depends upon your own experience, your skill set, and what is the grade of the nucleus that you're going to tackle. So these are the things that happen with a small pupil. As I said, it leads to intraoperative floppy iris prolapse, surgical trauma to the iris, shallowing, worsening of the meiosis. And once you have an inadequate visualization of the structures, that's when it leads to the main complications, which is corneal endothelial damage and even a posterior capsular rent. Now, what is my surgical protocol for small pupils? So first of all, I make a small paracentesis with a 1.0 millimeter side port, and I inject non-preserved intracameral phenylephrine with tropicamide. So that is phenylephrine, and this causes the pupil to get a little dilated. Then I use the ultimate soft shell technique, which is basically I would inject first a dispersive viscoelastic such as Viscoat, and then I would inject a Helon 5, which is my main tool during these cases, and a little bit of BSS under that, which is just coating the anterior capsule, which makes the making of the capsular rexes a little easier. Use a small incision always. A 2.2 is preferable to a 2.4, is preferable to a 2.8, and make the incision small. Use very low amounts of fluid for hydrodissection, very important over there, and do a very slow motion phaco with low vacuum and low flow rate so that you don't have much of turbulence in the anterior chamber. And use of hooks and irises, iris hooks and various retractors depending upon the size of the pupil. So while there are various techniques like stretch pupilloplasty, iris hooks and retractors, and Malaysian rings and B-hex ring made by our own Suvin Bhattacharya, and the BD expansion devices. So I'll just, since it's a video-based session, we'll just go to that video straight away. So this is the case where, sorry. Okay, so this is a case where I have used iris hooks. So I make 4 incisions which are opposite each other, almost at 90 degrees apart, using 1 millimeter knives only. Then we put the iris hooks. I prefer the iris hooks from Alcon, which are the Greisaber hooks. The advantage is that they can be used any number of times and they last you for a very, very long time. They're very easy to put. One little tip is that when you are making those incisions, make sure that your incision is not absolutely parallel to the iris, but it should be directed towards the pupillary edge. That makes placement of those hooks a little easier. And then you can keep on stretching them as much as you want. In some cases, I even use a 5th hook under the incision to keep the iris away from the main port. So once you've got that, then it's very simple. You have to make another side port incision through which you will go and commence your capsular rexes. And the capsular rexes should be as large as possible. This is one of my initial cases. If I were to do this again today, I would make a much larger rexes than this, because we know the advantages that a large rexes brings. Of course, it should be large, but yet small enough to cover the optic all around. And then go through the main incision, go with a 2.2 millimeter incision, a minimum amount of hydrodissection, and that is enough. You don't need too much. Make sure that you rotate it well. And then, of course, you proceed like a routine phaco. And once you have got all the nucleus out, you do your cortical aspiration, you do your capsular polishing, and you're good to go after that. So basically, the rest of the procedure is quite simple. And once that is done, you're almost with it. So I think we are left with the main, we are injecting the lens now. Make sure the lens is in the bag. In this case, I think it's a toric lens. And to get the sutures, the hooks out is very simple. You loosen the strut, and very often it just comes out, or maybe you need to sometimes push it in again. And that's the end of the surgery in this case. Now, here is a case of, again, a small pupil. And this case was a case of a person who was taking tamsulosin. He was taking Urimax for his benign prostatic enlargement. And I'm using the Varion because I'm using a thing over here. And here again, the strategy is the same. You make your regular side port incisions. I insist on a 1 millimeter side port incision. The 2.2, and here comes the Malaysian ring. You always put it bevel down first, so it becomes easier to go in through the incision. If you go bevel up, you'll hook against the incision and cause a Descemet's detachment. Then make sure that you open it in the same plane. So in one shot, you have all the 3 hooks inside. Not very easy, but if you can do it, it would be great. And then you put it inside. You go ahead with your capsular rexes as you go in a normal routine case. And the rest of the procedure is just almost like a routine phaco. You basically ensure that you have a good visualization of all the structures when you're going ahead with these cases. The lights can be lowered. Can people see, or should we lower the lights? It's okay, yeah. And of course, goes without saying that you have to rotate the nucleus in all these cases because you can't leave anything to chance. It's not a routine case. So you want to make sure that your lens is rotating before you go inside. The biggest advantage of this ring as opposed to the hooks is that it maintains a uniform anterior chamber. When you have the hooks, you have the iris coming up to the wound, so your anterior chamber is not in its most physiological state. So I always prefer a Malaysian ring or even a B-hex ring to ensure that you have a good, nice stable chamber, less chances of any damage to the endothelium. And here is your lens coming inside. Of course, the more interesting part about the Malaysian ring is how to take the ring out, and I'll try and show you that right now. See, first you release the inferior scroller, and then you go for the upper one. It's a little difficult to engage it the first time, but once you have got the first two, the inferior, which in this case is the nasal, since I sit on the temporal side, and then the temporal, then it's very easy to engage it in the hook and get it out. And here is the case where basically we have done a femtosecond laser capsulotomy for this patient. This patient is again a patient who is taking prostatic medication. He's taking Flomax, and we know that this pupil is not enlarging very well, but we managed to get a 4.5 rexus, and we know he's going to have intraoperative meiosis. So here you can see your CCC is almost close to the edge, and even that minor touch to the iris is going to cause that iris to contract, the pupil to contract, and as you can see, the pupil is going to go small. Now, did I put in a ring here? No, because first of all, the nucleus didn't have much density. It was grade 2. I think I'm sufficiently experienced by now. And at the same time, I knew that I've already done a femtosecond laser-assisted nucleotomy. So my fragments are easily made. One thing which I want you to appreciate in these cases is that whenever you're doing the initial steps like the sculpting or the chopping, try to do it one-handed. It's much, much simpler. What it does is when you put in your second incision through the side port, and if you slightly even depress the sclera over there, the iris pops out over there. So try to maintain as much physiological chamber as possible because the phaco incisions are geared for the needle with the phaco sleeve, so there's less chances of leakage over there, and the case is over. And the last case here is an interesting case. I've done a femtosecond laser capsulotomy and nucleotomy, and you can see the pupil has contracted. In fact, if you see, you can see the anterior capsule over the iris, and see how quickly this case will get meosed. You can see me picking it up. It's always better to pick it up because in case there are some bridges over here and you pull, then you'll suddenly have a rexus running off to the periphery. Again, go bevel downwards, and then of course, when you can see the pupil is so small, you have no option but to put in a ring to kind of enlarge that pupil. This case, it was difficult to get the superior and inferior ones in this first shot, but don't hesitate to stretch it out slightly because both the iris and the hook are extremely flexible. And once you have this in place, and you make sure, of course, that your ring is not engaging the edge of the rexus because that can happen sometime. And then, of course, once you go in there, it's all simple and you get it out. In the interest of time, I think I would conclude out here. That was the end of the procedure, and thank you so much. Yeah, you can have questions.
So what do you feel, the BX ring versus your mannequin's ring? What is the preferred one in your personal experience?
So,
leaving the cost aside.
Yeah, leaving the cost aside. Yeah, so I'll tell you, the BX ring is also very good. It's not as stiff as the Malaysian ring, and it does not dilate the pupil as much. So the BX, in my experience, goes only up to 5.5, and so my rexus tends to be a little smaller. When you have a smaller rexus, more chances of phimosis, more chance of cellular proliferation on the anterior surface of the IOL. So I would prefer a Malaysian, but if I have a soft nucleus, then, if the meiosis is not too bad, You can put in a BX ring and make sure now you make the rexes as close to the pupillary margin or beyond. So then that would make the job easier.
And what about the medications which the patient is taking usually for the prostate? Do we stop them?
No, we don't stop any of the medications at all because it makes no difference. Even though the patient has had prostatic surgery and has stopped taking the medication long back, the effect of those medications remain. So I never stop, never stop.
I usually prefer, because I was not stopping it, but I've had patients where one eye, the pupil gets constricted so much, and when I stop for 7 days, at least that pupil is a little comfortable to manage.
I would advise you to start injecting the phenylephrine and lidocaine combination in all cases of these sorts, even before you start. You don't find that much.
Okay.
But I found that it doesn't really make a difference. And once it starts coming out, then you had it because it's going to go on and on.
It's going to go on.
Thank you. No. I was advised that. I used it again. I found no difference. I think the single most thing, and I haven't had a major complication with IFIS for a very long time, is the slow motion, low vacuum, and low flow rate. My flow rate is as low as 12 cc per minute. With that kind of 12 cc a minute, and with an IOP, I use a Centurion machine of 30 millimeters of mercury. I've never had a problem for quite some time, touch wood.
Can I add one point?
Yeah.
Construction of the wound is also very important.
Very important. That's another thing I wanted to make in Raksha's case. You said sharp instruments. I would say the compromised cornea is one where I'll use my sharpest knife because I don't want any descents to complicate matters. If you use a knife with which you struggle to go inside, be sure you are going to detach the descents at some time because you're going to be so many instruments going in and out. Other thing, as far as possible, don't take out the instrument when doing on a compromised cornea. Do it at one shot. Try to finish the phaco in one shot,
Sir, I have one more point. So when you have the phaco and the fluid veins on the side, so usually with the torsional phaco, we tend to tilt the irrigation. So the irrigation goes up and down, and that is
No. When
Did
you
you-
are tilted, the irrigation should be pointing sideways.
Yeah.
that doesn't cause the ephes to worsen so much. But when you do it sideways, the irrigation goes up and down.
Whenever-
Every time we see the fluid.
No,
Whenever I am arranged the sleeve in such a way that it is going sideways when my port is like this. Always. all cases.
you have to. I mean, you can't have this whole pointing upwards. Yeah. So what I do is now, for example, in the Centurion, my thing is pointing towards the bevel of the needle. Then you're sure that it's not going. Thank you.
Thank you.
I will just come.
Yeah, come. So, good afternoon, friends. Thank you, AIOC, for giving me this opportunity. I'm going to talk on taming the posterior polar cataract. So, it is something which we come across every now and then, and every surgeon has to be very well aware of how to deal with this. So why? Because in PPC, most of the times the posterior capsule is weak or deficient. In a study conducted by Bobby Osher, the risk is as high as 1 in 3. Okay, so that's very high. 33% of the times your chances of getting PC rent, and in today's world that is just not acceptable. So, and it is very important that we differentiate it properly from a PSC. So in PPC, it's like a onion peel or bull's eye target kind of a picture. Whereas in case of PSC, it is a disc or a sheet, in the center of the posterior capsule. Pre-operative examination, careful slit lamp examination to differentiate between PSC and PPC. Rent, sometimes you can see on the fundal glow, and AIOC is very important to understand the integrity of the posterior capsule. So here is one picture where you can see the glow even before the cataract is removed, and on the other side AIOC is showing that the PC is deficient. Sometimes PC is formed, but there is no gap between the cataract and the posterior capsule. Okay. Now here you can see that there is no gap between the cataract and the posterior capsule. There is a gap between the cataract and the posterior capsule. I will show you later on a case of PPC where there is no gap. Okay. Then preoperative consideration, operate as early as possible only when patient has visual disturbance. Don't disturb the eye, because if you get a PC rent and complications, we are going to have tough time. So whenever the patient starts complaining, after that don't wait, because harder cataract is more difficult to remove. Counseling is very, very important. We have to be very, very transparent. Later on it becomes very difficult to explain. You should have multiple IOLs ready and vitrectomy and retinal surgeon on call. Now the principle is very simple, that you have to be as gentle, as much gentle to the posterior capsule as possible, otherwise, capsular axis is very important because sometimes CCC is a savior, and you can either do keep a 3-piece IOL in the bag with optic capture, or you can do a lot of other things. We have to use high density cohesive viscoelastic. So cohesive viscoelastic I want because I want the anterior chamber pressure to be maintained now, whereas during phaco I will have dispersive viscoelastic because I want to make a volume there, but I don't want to cause undue pressure on the posterior capsule. So this is one place where cohesive and dispersive we can use differently. The CCC has to be 5 mm and centric. Hydro procedures, hydrodissection, of course no. Hydrodelineation, yes, if you're confident. Hydrodelineation makes it the case very simple, and it separates the rest of the epinucleus from the rest of the capsule, and be gentle. Vigorous decompression of the bag has to be avoided, and that's why the hydro procedures have to be done very, very gradually, and nuclear rotation has to be avoided if you're not sure that you got the hydrodelineation properly. Then phaco, do a slow phaco with low parameters, very low bottle height and flow rate. We have to avoid fluctuations in the anterior chamber. I've had a situation where PPC, I finished everything, and while hydrating the wound in the end, I got a PC ring. Luckily, by the time Iol was in place and nothing happened, there was no break to the anterior vitreous face, and the patient did well. And he was a celebrity. So sometimes you get into such a situation, So basically, you have to be very, very gentle with the all the maneuvers, including phaco. Emulsification has to be done without maneuvering, and friction to the PC has to be avoided. So either you can do peeling separation, okay, and use dispersive viscoelastic, the point which I already explained. Depulging the nucleus is the first step. Prolapsing the pieces of the nucleus or piecemeal. So there are multiple techniques. Sometimes you can prolapse the, like a pizza pie, you can prolapse it, or sometimes you can take it piecemeal by small pieces. And the removal of the opacity has to be left as early as possible. The upper half of the nucleus, or the cortex and the plate, has to be done either by manual separation or by visco separation. Irrigation aspiration, same principles again. Don't overfill the bag. And polishing, Dr. Nagvekar does polishing routinely, but I don't do it. I leave it for yak capsulotomy later on, because you're too scared that you will rupture the thing. Again, overinflation of the bag has to be avoided. Iol implantation with a snap. Okay, I have had a patient where toric, plate haptic and trifocal, and it just snapped and gave away. So after that, what I started doing, I first put the lens in the bag, in the in the AC, and gradually tuck both the pieces, loops inside, or whatever. If it is a plate haptic, then one by one, all those 4. Then if there is a PC rend, first thing is that we have to do vitrectomy. If there is vitreous, just be very, very sure that your vitreous is removed. And it is possible sometimes to put a single piece lens in the bag if you manage to do CCC, posterior capsular axis. But many times the tear is oblong and you can't do it. But oblong tear has an advantage that you can put the lens across the oblong tears, and therefore many times you can still put the lens in the bag if you go very genuinely. And of course keep the 3-pins lens ready so that it is you can put it in the sulcus. Now this is video number 1 where I have taken the cataract piecemeal. It appeared to be a high grade cataract from the color. Now I have done hydro. See, what happened is that because of the high grade, I was not sure that hydro delineation has occurred properly. So I went piecemeal, taking the pieces one by one. And then at one particular point, I realized that see over here, I realized that the plate is getting separated. So then I went for manual separation of the plate. I took my phaco probe out, and with the help of I'm still getting it piecemeal. Now once I realized, okay, now I went in with a dialer and separated it completely, and then it was easy to take this epinucleus out. Now we'll look at the Lensex or the Flax. Flax offers 3 advantages in PPC. Number 1 is that you can place the CCC. You get a time to place your CCC properly. Just imagine Sachin Tendulkar getting chance to think of the ball, plan in advance. Then he would have probably scored 1,000 centuries. Okay. Then second advantage is that that cylinder pattern, if you see in the center, it is very good in debulking the nucleus. And the third advantage is that pneumodissection is done, and therefore hydro procedures are many times not required. So let me forward it slightly. Yeah. Yeah, see, you see the air bubble being formed. Previously, we were worried when a long time back we used to use lot of energy, but nowadays we are using only 1/3 of the energy as what we were doing in the beginning. So air bubbles are not too many, and you are very sure. Similarly, always keep a watch on whether there is at least one small hole in the anterior capsule where you are doing CCC, so that there is a chance for burping of the air out. Now, this is another video I would like to show you. Just look at the hydrodissection, very gradually. Thanks to Dr. Nagvekar, I have taken the video from him. Hydrodelineation has been done very slowly, gently. Okay, but he was probably still not sure whether hydrodissection is, delineation has been done or not. So what he did repeated hydrodelineation. Now again, second time we are doing hydrodelineation. Okay. Now, because of this, it has become very easy to rotate the nucleus. Once you are sure, then you can rotate the nucleus. I'll forward it. And then take it piecemeal. And most important point to see is that you can take the now see the disc is still remaining, and it is being taken now gradually. This is perhaps the best demonstration that you could achieve hydrodelineation, and you could rotate the nucleus, and the disc is kept till the end. Okay, because of paucity of time, I deleted the video of posterior capsular polishing, and I left Iol management to the next speaker. Thank you. Usually, in my counseling, I don't give verdict. I leave it to the patient. So I tell him that if you do the cataract early, this is the benefit, and these are the complications you are likely to do. At the same time, it is not an emergency. Whatever you feel, you choose. So today many patients go for second opinion and all this. So we are giving them an option, and invariably, if you give proper options to the patient, they come back. So I will not take the call myself.
And suppose you land up with a rent during your nucleus management. Yeah. So what would you do? Do you go ahead with the phaco, or you try to get, let's say if it's a hard cataract, and you have a significant amount of your nuclear fragments which is still lying there? Yeah, so
see, that becomes a very, very difficult situation. What I will do is that I'll try to put, first of all, I will not withdraw the phaco probe immediately. From the other side, I'll try to put some visco stop the irrigation, then go underneath the nucleus and put the heavy cohesive visco underneath, and I'll try to put the nucleus pieces in the angle shelf and then take them one by one. Over here, if you want to be really very sure that you are not going to put a lens now, any premium IOL, then you can put 3-piece IOL in the bag and use that as a scaffolding. So the chances of the nucleus going down decrease.
For that, your anterior chamber has to be deep enough. If you have shallow anterior chambers, would you be?
Once you have got a PC rent, you are not that much concerned about the depth of the anterior. You can make it as deep as you want.
So your preferred surgical technique, Lensex versus the femto versus manual?
Any day, Lensex is, it has got definite advantages.
In PPC?
Yeah. I'm talking about PPC. Huh.
Yeah. Thank you, sir.
Thank you.
Any other questions?
Can I add one point regarding hydrodissection and delineation? There is a Dr. Vasauda, and he has mentioned about inside out hydrodelineation. So you don't do any hydrodissection, but you start phaco, debulk the center. So by doing that, you are actually doing inside out hydrodelineation. And another point is that you can do separation mechanically by using a Sinskey hook instead of injecting fluid mechanically. These 2 points I just wanted to add.
Yeah, actually I covered those points, but what you said is correct. See, during the third video, which was given to me by Dr. Nagvekar, so
Actually, he was doing that.
Yeah, exactly. So what he's doing, he did first small hydrodelineation, very minimal, and as you are doing phaco, the fluid anyway seeps in.
Actually, it creates the wave and separates. And
exactly.
Another point which I wanted to add is, while doing irrigation and aspiration, the central plate you don't remove, you just pull it to the center from all the sides as if it is a flower petal. Don't remove everything, because if you pull it, then maybe the chance that you will avulse the whatever thing has happened at the process. So you bring everything in the center as if a flower petal is there, and then remove gradually, and at the same time you put visco, so that there is a less chance of rupture of posterior capsule. That is how I do.
I would like
while
to
doing eye.
See,
for cortex.
definitely this is one way, but sometimes what happens that when you are removing that disc of the PPC, you eat up the cortex, and you do not have any handle left to remove the PPC.
So don't eat all the cortex. You just bring it to the center, leave it.
If you bring it to the center,
from all 4 quadrants, you bring it to the center separately, so it looks like a flower.
My worry is that if I eat it up, all 4...
You don't eat, you just pull it to the center and leave it there.
Fine.
One question, do we have time?
Yeah.
If you have a combination of small pupil with PPC?
I love...
Use iris hooks.
I use iRing. It's a device by some person in Delhi. He's a dealer. iRing, you can see videos. It's a green colored ring. The best part of this iRing is that you get more than 6 millimeter dilatation, and it is flexible. And you look at it, immediately.
Gupta ring.
Gupta ring. Yeah,
it's very
fantastic.
Bulky. So if AC is shallow, you cannot use it. It's bulky.
AC shallow, that's a problem. Thanks.
Thank you.
So thank you, Dr. Nagvekar, sir, to have me here. So I'll be talking about supporting a sagging lens. So basically talking about the zonular dialysis. Arya? Yeah. So weak zonules, basically there are many risk factors for it. So there may be pre-operative conditions where you can see the zonular dialysis. So these are usually traumatic cases that we see in our clinical practice, or pseudo-exfoliation. The other conditions where you see an extreme degree of zonular laxity is the Marfan syndrome, homocystinuria, all the congenital conditions where you will see a 360-degree laxity of the zonular fibers. The other factors are intraoperative factors. So if you have a brown cataract, so you're likely to land up with more manipulation, and there is a high risk of zonular dialysis that you'll have. The other things are the surgical complications. So if you are wanting to hurry up a cataract surgery, and probably you'll land up with complications, and if it's a novice surgeon. So one has to be very careful when you're doing a cataract surgery in difficult cases. The post-operatively, you can even get Iol subluxation if the intraoperatively one could not identify the zonular dialysis. Pre-operative assessment is very important. So careful slit lamp examination will be able to tell you whether the patient has weak zonules. So either a presence of phacodonesis. So phacodonesis will be there if you have a more degree of laxity of zonules. But where there is only, let's say, 2 clock hours, 3 clock hours, you may not be able to see a significant phacodonesis. So you have to have a very well dilated pupil pre-operatively to evaluate the absence of zonules. So if you have a history of trauma, you must look for it. So pre-operatively, many times in the OPD, we do not dilate the patients fully if you want to rush the patient. So please carefully evaluate these patients pre-operatively to look for the subluxated lens. Third thing is that you have to look for the vitreous prolapse in these areas, in these cases. So if you have a vitreous prolapse, you'll have to intraoperatively manage the vitreous prolapse before you go ahead with your cataract surgery. So the cataract surgery in weak zonules, the main important, I think, component is your ECR and ECR segments. So the type of endocapsular ring that you would use would depend upon the degree of zonular laxity that you have. So you have about 2 sizes, that is 10 by 12 millimeter and 13 millimeter one. So with the eyes which are longer, having longer axial length, you can probably take a 13 millimeter endocapsular ring, but it's very difficult to insert that. So in my probably whole experience, I have only used the 10 by 11 millimeter endocapsular ring. You will have to use the lens hooks to support a lens which is having an excessively lax zonule. So if you have more than 180 degree of zonal laxity, then you will require the lens hooks to support the lens while doing a phacoemulsification. ECR segments, so you have Sioni or Ahmed. Locally you have, I think, Gupta segment which is available. I have used only once, but that also comes to your rescue when you have a larger amount of zonurodiolysis. And you have to use it with scleral fixation sutures. There are available modified ECRs with single eyelet and double eyelet for scleral suture fixation, but they are very difficult to handle. I think in my experience, I have not been able to use them. And capsular anchor devices have been used by some of the people. I don't have my personal experience in that. So when you come to a surgical technique, one can perform a phacoemulsification, which is my preferred technique, or can you even go ahead and do a manual SICS or a partial expression of nuclear fragments if you feel that the lens stability is not, the capsular stability is not good enough intraoperatively. When you have the congenital conditions with lax zonules, many a times the lens is usually a lot dislocated anteriorly or posteriorly. So in these patients, probably one has to go with an intracap technique or a pars plana lensectomy. So the intraoperative problems that one can get is the extension of zonular dialysis during your cataract surgery. You can even get a vitreous prolapse if you are not very careful in managing the cataract removal during the phacoemulsification in a patient with zonular dialysis. One can have a nucleus drop and a posterior capsular rent, or you can have even a broken or a peripheral extension of capsular excess if you are not very careful while making it. So the techniques for ECR insertion, one can do it from the main or the side port. One should usually avoid the entry at an acute angle in the capsular bag. Otherwise, it will tend to pull the zonular fiber, the area of the lens which is without the zonules, and you can increase the zonular laxity. One can use either directly or you can use a preloaded injector. And the size I have already talked about. The stage of insertion of ECR. So my initial days, I used to always prefer using it post-hydrodissection because I was scared about the lens drop. But off recently or more recently, I usually prefer it either after the nucleus expression before the cortex aspiration. Intraocular lens selection. So, with the types of devices that we have nowadays, it's possible to put an in the bag intraocular lens in these patients. So, very rarely you'll have to resort to a scleral sutured IOL or a glued IOL or a Yamane technique or an iris claw. ACIOL, I think, is probably nowadays nobody is doing with the other IOLs that you have available. So, this is one of the surgical video. So it was a young patient, post-traumatic, and he had zonular dialysis in two areas opposite to each other. So they were about 2 or 3 clock hours on opposite meridian. So since I was not sure whether the endocapsular ring alone will be able to cover the entire area, I decided to make a scleral pocket initially. Performed a capsular excess. Now, it is important to start your capsular excess away from the area of zonule. Now, in this patient, while I was performing and when I came near the second area of zonular dialysis, I went into the anterior zonular fibers. So I think one should avoid that, because once it goes there, you'll have it. Sometimes becomes very difficult to bring that rhexis back in this thing. But then if you have a very strong centripetal force with the help of capsular rhexis forceps, you'll be able to get that rhexis in the center. Fast forward nahi ho raha hai. So you do a routine hydrodissection. I think it's very important to do a good hydrodissection and hydrodelineation in these patients. And perform your routine phacoemulsification. Prefer a chop technique rather than a divide and conquer technique. So here now I'll be putting an endocapsular ring because I usually prefer before the cortex wash. So always avoid the acute angle. Try to see that which position will cover the most of the zonular area, because sometimes, so in my initial days I have done the mistakes where the zonules, the area of zonular laxity did not have the complete endocapsular ring coverage. While doing a cortex wash, you have to be not using the centripetal force in the area of zonular dialysis. It's usually preferred to have a tangential or a lateral force to remove the cortex wash. सेकेंड स्लाइड शो में कर सकते, इसमें नहीं चाहिए मेरे को ऐसा, वो फास्ट ये नहीं कर पा रहे हैं फास्ट फॉरवर्ड, एस्केप करके I'll just yeah sir I'm not able to play slideshow. Okay, I'll do that. Yeah, यही आ रहा है, जाने दीजिए. So they ये नहीं है, हाँ, because it's going into that slideshow मध्ये, it's going into, I don't know how to remove. No, I'm not. Okay, I'll be able to do it with this. Yeah. Okay. So I think once this was done, I realized that nice, sir, it's going to the.
Just do forward and backward.
हा व्हिडिओ आहे ना, याच्या इथे खाली अशी लाईन येते ॲक्च्युली.
सर याकडे नाही येते कारण हे असं वाला शो आहे ना, I don't know how to remove it.
अच्छा अच्छा, असं आहे का?
Otherwise, you come out of the presentation, show video directly.
Yeah, I'll do that. That is better. So it was this patient, yeah. Yeah, so once that was done, we went ahead with a routine single piece lens. It's not seen? दिख नहीं रहा है क्यों? Full screen करूँ?
Till that video starts, can I say something?
नहीं आ रहा है.
Vavi. Till the video starts regarding capsular axis, which the previous video she
कैसे?
was showing, na? The capsular axis was extending to the periphery, so it is better to deepen the AC and then do it again. You could see that she did not put visco, so it was going to, and then the pull was also more. The second thing was that the anterior complex of the zonules was weak because there were wrinkles on the anterior surface of the capsule. So when you start capsular axis and when you see that there is a wrinkling of the anterior capsule, that means the zonules are weak.
Next
Okay.
slide करूँगा, so then we'll be able to.
Very good points. So I can also add few. If you over deepen the anterior chamber, again the tear will extend to the periphery.
Click on it.
No, I agree. I'm just adding to what you're saying.
हाँ दाखवत का नहीं माझ्या ह्याच्यामध्ये.
Show now. Go to the next
Yeah.
one.
No, nothing, sir. Yeah, so this is another patient where there was a small pupil. It was a post-vitrectomized eye, and there was an air escape and patient had a secondary glaucoma in the immediate post-op. So patient landed up with mature cataract. So at this point of time, obviously we knew that there was some amount of lens touch that the patient had. Again, my video. So in this patient, so there was a zonular dialysis, and the moment I tried to remove the synechia, my pupil was down. So I used the iris hooks. I think I used the B-hex ring here, and dilated the pupil. So we could see the extent of zonule and that there was about 3 or 4 clock hours of zonular dialysis. So we did a capsular access in this patient, and it was uneventfully managed. And post that, we tried to remove the cortical wash. The only one thing that we realized here was that the capsule was fibrotic in the area of zonular dialysis. So it was very difficult to so we had to do a use scissor to get the access done in this area. And to our surprise, this patient did not have any nucleus. Okay, so so I didn't realize that because I had a standby retina surgeon. So we went ahead and I did the cortex wash manually. So I did not go ahead with the IA. And we were able to do it. And once we did it, I saw that there was a large PC rent. So I decided with the iris claw lens because I didn't have much option because this would not expand because of the fibrosis. And once we finished and we had a look at the retina and we realized there was a nucleus. So the retina surgeon came in and he did a phaco-fragmentation. So this is another video where there is a large amount of zonular laxity. I think it's not running. So here we had okay. So it was a hard cataract, so we used the Blu-rays. So the video is not very good because it was an old video taken from a DVR, so it's not going to be a very great video. But this patient had about 160 to 180, so you can see the superior whole area which was having a zonular dialysis. I think I'll escape this because it's in short. Yeah. So post-operative complications, sometimes you do a surgery very well, but you'll still have a problems post-operatively. So Iol decentration. So this is a patient who had a traumatic mydriasis with traumatic iridodialysis. And we had done a pupilloplasty with a cataract surgery. Fairly good centration, but you'll see after 2 years, there is a capsular phimosis and the lens is got updrawn. And And the second one is a patient who, again, where there was only an endocapsular ring which was inserted. The lens was very well centered, but you can see the capsular excess margin coming in the center. And you can land up with obviously vitreous in the anterior chamber, secondary glaucoma, and retinal complications like CME and retinal detachments are possible. So to conclude, zonular dialysis management needs a careful planning pre-operatively. OT should be well equipped with all the this thing. So you should have rings, segments, sutures, and all variety of IOLs. And your plan B should be ready if you think the plan A has failed, because you cannot decide the second line of treatment on table. So it should be pre-planned, and it's possible to implant an in-the-bag IOL in most of the cases instead of using a sulcus sutured IOLs or iris claw lens. Thank you. Sorry for the video.
One small question.
Yes, sir.
For pupilloplasty, this looks like older technique.
I still do older technique. Yeah, the 4th row single pupilloplasty I'm not doing still.
It's very easy. and
Yeah, I know that.
There's no learning curve for a surgeon like you.
Sipes are not.
Yeah, SIPs are not.
Yeah,
But
that is the old technique. But except like the single pass 4th row is really easy. Very, very
yeah.
easy.
Thank you, sir.
So one more trick for the people who start using a ECR for the first time is to put a 10-0 nylon thread through the eyelet, so that if it gets stuck somewhere, you can just pull on it and go on advancing it through the bag. So that's something that you should keep in mind. My first 2 cases as a resident were PC rents. And that was the day I decided that I should not be scared of PC rents. So these are the case scenarios that we would be discussing. Case 1 would be a PCR with the entire nucleus in the bag, and that's what we don't want, a nucleus drop. Case 2 would be a PCR, a toric IOL is planned. Case 3 is 1/4 PC support absent and a toric PC IOL is planned. And case 4 is a small pupil and I have a PCR with the nucleus in there. So this is one of my fellows who's doing it, and he or she, I thought that, okay, no, let me take over, and this is what I have done, not the fellow. And I have a rent out there, and I don't know how big. So I use a dispersive viscoelastic without shutting off the irrigation, and now assess the situation. My CCC is intact, that's for sure. And like Dr. Nagvekar was telling, you should get all these fragments into the anterior chamber shelf and keep the fragments in the area which you feel that the PC is intact there itself. Don't get them, all of them out there, because then it's going to cause more turbulence. And then slowly, after decreasing your parameters, you can actually, if you've seen, my normal aspiration is 26, I've dropped down to 20. My vacuum is 550, I've dropped down to 400. And I remove off all the pieces one by one. So this is something which I got adventurous after listening to seeing Osher's video, which said that the vitreous is a scaffold, and if the vitreous is formed, it's not going to allow the nucleus to drop down unless you churn it. And you churn it only by having higher fluidics. So the most important thing out here is to decrease your fluid level that's going in and out. Drop down your flow rates, drop down your bottle ride, drop down your vacuum. So after doing a staining with triamcinolone, this is the vitrectomy which is being done. What I'm showing is the use of alternate between IA cut and cut IA as a vitrectomy. So this is a very important mode that you should be using in your vitrectomy, in which you can use it as an IA thing as well, and sometimes you can use it to cut. So you should be toggling between the 2 modes. Now, because the PCR is very big, it's like half the PC gone, I'm not going to attempt to put anything in the bag. This is a 3-piece IOL which is being put in the sulcus. A way of putting the 3-piece IOL is to have the bevel up on the left side and then slowly rotate it so that the haptic opens up in the plane of the iris. Now you dial it in, and I usually like to keep my rexes at around 5.5 mm, so I'm able to do a posterior optic capture in this patient as well. And it sits very well. And this is going to center and be centered perfectly because it has adequate support. Form the chamber at all times. See to it that the chamber does not collapse and become soft. Like Dr. Nagvekar, even I like to do a rigorous PC polishing, but if I don't check the edges of my bimanuals, this is what I get sometimes. Fortunately, there is no vitreous tag which is there. I have put a dispersive viscoelastic. This is a small technique you should master because many a times the flap tends to go into the vitreous and it's difficult to hold it. So you may use a second instrument to do assisted PCCC and complete the PCCC out here. And because this patient was for a toric IOL, I could end up putting in a toric IOL and it's a happy story. Now here the most important thing again is try to decrease the manipulation of the IOLs. And when you're trying to remove the viscoelastic from behind the IOL, see to it that your chamber is very well formed and your aspiration is low. Because if at that time your aspiration increases, you tend to churn up the vitreous and the vitreous will start popping in from the PCCC. It's not difficult to manage that, but you'll have to end up doing a vitrectomy again. Now here I have a big triangular rent. It's like a quadrant gone. Now definitely I'm in a soup and I have a toric IOL to put. I'm trying to do a PCCC. It's going in the periphery. So this is something that now I am not doing this. So now I take a deep breath, pause, and now I think, what am I going to do? So I say, let's try this. If not, then I'll have to explant it. So I put the IOL in the area which is intact first. The haptics go in. My IOL gets placed in the axis. And I attempt to do an anterior optic capture for this. So now once I'm sure that that area in which the haptic is gone is the area where the equator is, now I have shifted the entire IOL into the axis. So the important part is the knuckle should go into the equator because there still is some support out there and you want the haptic to be there and the optic is to be held in front of the rexis any which ways. And it's perfectly sitting well, stable. Tap on it, see, do the trampoline test. Now we have this case number 4. I had operated his first eye, small pupil, and I was confident, oh, went very well, not going to happen, let me not put any pupil expander. And I'm going very confidently, ho raha hai, sab ho raha hai. And now suddenly I feel a giveaway and there's a surge out there and some part of the nucleus start tilting. So I slow down. No. Something is wrong there again. And I'm not able to see the PC here. There's the surge. So I increase. The pieces are starting to come up now here. Luckily, because of the low fluidics, I'm able to not drop the nucleus fragments down. I'm getting them into the iris shelf with the bimanual technique. So I'm using an iris hook in one hand and a round iris spatula in the other. And I'm checking at the same time whether my rexis is intact. So whether it's a rexis tear which has gone behind or whether it's a PCR independently. And now the pupil also has started coming down. Now, unfortunately, with small pupils, even if you do use phenocaine or any dilating agents intracamerally, they are not going to give you a full dilatation once the meiosis starts. So you're not going to be able to see your excess margins if it's around 5 mm or 6 mm. So here I put a Malugin ring after I have done all the manipulations so that I can see where the rent is and manage the rent, where I can see the rexus margins and manage the rexus, manage the Iol placement. So again here half my PC is gone, so he was planned for a toric Iol. So we had to do with a 3-piece Iol in the sulcus. So this is the use of the eye cut mode of the vitrectomy, which is a good mode to use whenever you have PC rents. And there we are putting the IOL in the bag, and we would do a reverse optic capture for the same IOL. I'm done. I'm perfectly done. It's just. I'll just wrap it up. So to summarize, we need to have dispersive viscoelastics, slow-mo phaco with lower fluidics, microrexis forceps ready. You need to convert to a PCC whenever you get a rent. Don't wait for it to increase. Vitrectomy is always kept ready. You need to use both the parts of the vitrectomy, the eye cut and the cut eye. That's very important. Keep pupil expanders ready in your OR. CCC, try to put it at 5 to 5.5, and always have a library of 3-piece lenses. Dar ke aage jeet hai.
I would like to thank Dr. Nagvekar and AIOC to give me this opportunity on talking. My best attempts at implanting an IOL, the different IOL techniques in implanting a lens in cases of a complicated cataract surgery. Generally, we would be faced with either weak zonules, anterior capsular tear, or a posterior capsular tear. Anterior capsular tear, if it's a radial tear, single radial tear, an IOL can be placed inside the bag. If there are multiple tears on the anterior capsule, an IOL can be placed in the sulcus. For a posterior capsular tear, it would be good to evaluate the size of the PCR. I think a lot of this has been covered by the previous speaker. Lens can be a single piece hydrophobic lens can be placed in the bag. Prior to this, a thorough anterior vitrectomy should be done. If it is not extending in the periphery, of course, a single piece hydrophobic lens. A posterior capsular excis can be done to make a circular opening, not if the tear is not extending into the periphery. If the posterior capsular defect is large and with an intact CCC, an IOL can be placed in the sulcus, and if the CCC is central and if about 5 millimeters, the optic capture can be done. Once an IOL has been placed inside the bag, and if there is a PC tear, posterior and the posterior capsule is ruptured, a reverse optic capture can be done. For placement of an IOL in the ciliary sulcus, ideally the power of the IOL should be reduced by 0.5 to 1 diopter. If it is in the higher 20s, then up to 1 diopter. A single piece IOL should be avoided because of the thick haptics which are likely to rub against the posterior surface of the iris, causing uveitis, glaucoma. Ideal lens would be a 13 or a larger lens. A PMMA lens with a 6.5 millimeter optic and a 13.5 millimeter haptic would be good, but would require a larger incision. 3-piece hydrophobic lens with round edges and a smooth anterior surface are also preferred choices. Avoid a negative spherical aberration lens because a decentration of 0.5 millimeter or higher would cause a lot of higher order aberrations. A good lens for implanting in the sulcus could be a Sensor or a multi-piece Alcon lens. In the absence of adequate capsular support, the lens options that we have would be an AC IOL, a posterior iris claw lens, iris fixation of the IOL to the posterior surface of the iris with a McCannell iris suture, and scleral fixation of lenses. Iris claw lenses, anterior chamber lenses have been there since a long time and we are all aware of them. This is a short video of anterior caps. Since we are short of time, I won't be showing this video of an ACIL implantation. The posterior iris claw lens has become very popular now because of the ease with which anterior segment surgeons can implant it. Prior to implanting it, a thorough vitrectomy needs to be done. Synechiolisis, and the IOL is plano-convex with a convexity forwards. A myotic pupil is preferable. There are special iris claw forceps which are used to hold the optic, and the enclavation can be done with a spatula or a 27 gauge cannula. This is a video of a posterior iris claw lens being implanted. The IOL is first placed on the iris. This will give us a clue as to where the claws of the haptics are likely to be. The AC is filled with a viscoelastic and there are special forceps which are used to hold the optic. There are two ways in which this can be done. First, the optic is being held and a spatula is passed from the opposite paracentesis to enclave the iris. Once this has been done, you can safely leave the optic because it is being supported by the iris. There is a change of hands and the spatula can be passed from the other side after changing the hands. The second haptic is now being enclaved after pushing it under the iris. This is the second video of again a posterior iris claw lens. The iris is placed on the IOL is placed on the iris. In this case, the enclavation is then there is a posteriorly sutured IOL which can be sutured to the posterior surface of the lens by using a Seepser or a modified McCannell suture. Posterior complications of iris sutured lenses would be IOL dislocation, uveitis, pigment dispersion, distorted pupil and bunched up iris. In absence of capsular support, the other option would be a scleral suture fixation. It can also be anchored with glue or intrascleral fixation of the haptics. I'll just show the videos of. Yeah, this is a scleral fixation of a PMMA lens with Gore-Tex sutures. This can also be done with a single piece lens, foldable lens. However, it should have 4 haptics to be able to anchor it well. There are glued IOLs and then the Yamanese technique. In the Yamanese technique, an intrascleral tunnel is created. At the end of the intrascleral tunnel, a sclerotomy is done. This is a case of a dislocated IOL. Once the two tunnels are created on opposite ends, the haptics are externalized by a handshake technique, and once the haptic has been externalized, it is passed through the intrascleral tunnel which is created. The edge of the haptic, 0.5 to 1 millimeter, are flanged by a low temperature cautery which is going to thicken the end of the haptics and prevent them from slipping through the intrascleral tunnel. The haptics are being flanged here. That is going to thicken the edge of the haptic and prevent its slippage from the intrascleral tunnel. Thank you for your attention.
Please don't go away because we have the keynote address by our esteemed speaker and the incoming president of the Maharashtra Committee. It's a keynote address.
I'm not going to take much of a time, and I would like to thank organizers and the instructor. Thanks for accommodating. I'll take 2 minutes. Yeah. And my talk is on changing trends in surgical training. No financial interest in any of the technologies which I am going to mention. When we all started as a resident, like Nagvekar and myself are contemporaries. 5 minutes, yeah. I'll finish in 5 minutes. Yeah, no problem. Yeah. So Dr. Nagvekar and myself were, yeah, good. Thank you. So Dr. Nagvekar and myself are contemporaries, and Sandeep is our senior, about 6 years senior to us. No, you are young. And at that time, the principle of surgical training was Halstead's principle of surgical training. So what is meant by that? That residents must have intense and repetitive opportunity. And we had that intense and repetitive opportunity. The volume of the OPD used to be very high. And we used to have OPD right from 8 o'clock till 4 o'clock without any break. So we had that intense and repeated opportunity to take care of surgical patients under supervision of skilled teachers. So who were our teachers? So I can ask Dr. Nagvekar, like seniors were our teachers. When we were junior resident, 2 years senior, he used to teach us. Because there were more of a honorary system rather than a full-timer system. And they were taught by their seniors, and they were taught by their seniors. So those seniors had become honoraries. So that's how we learned. But the thing was that we had an opportunity to see many patients, and it was more of a self-learning type. The second thing was that wet labs. In those days, there were hardly wet labs. We used to go to butchers and take goat size and pig size, you must be remembering. And whatever sutures were remaining, we used to catch hold of those sutures and then we used to try. There were no microscopes when we started. And I think the first surgery what we did was intracapsular cataract, cryo extraction with broad iridectomy. Probably Dr. Nagvekar must have done the knife section. But yeah, he must have started with knife section. And that is how now he is an expert phacosurgeon and a flak surgeon. So it's a learning process for everybody throughout. But for students nowadays, it's advantages. Now what is the advantage? Nowadays, we are talking of 3D printing. 3D printing technology, like you can print corneas and train the students, like at LV Prasad, they are already doing it. So see the difference. We used to go for and take goat size, pig size, try to learn on our own without microscope. In fact, we have done surgeries without microscope and used 10-0 suture also. So how we used to see, I don't know, God is great probably. But the new students have good access to technology. Second thing is for references. For doing PG thesis, you must be remembering what references we used to get. We used to go to some library, we used to ask our bosses whether you have any books, then they may give you those references. Or we used to visit conferences. There were hardly any conferences. I remember that there used to be only one good conference at Dr. Nagpal's place. Dr. Bhavishi and Nagpal, they used to have a conference. That's how we started learning. But in 1990s, there was advances in instrumentation, advances in surgical instruments, microscopes. In fact, when we were students, we had no access to microscope. Our bosses, there was only one microscope in our college. Our boss never used to allow us to operate under that microscope. So what we did was 3-4 of us pulled money, went for AIOS, purchased one Jaggi microscope, and kept that microscope in the operation theater, and we used to learn on that. But nowadays, these students have access to any equipment. The microscope with teaching scopes are there, the videos are there. And then came the era of internet, and it just opened the Pandora's box. 5G technology and connectivity has changed everything. So nowadays there are video assisted skill transfers. You need not attend any conference. You have huge number of videos which are available on YouTube channels of surgeons across the globe. You can go to the video channel of David Chang, see his videos. Topmost surgeons from the world, students have access. So go to those videos, learn from them. Last 2 years, COVID has halted everything. Nothing was there. But then the other side, for teaching, it was a boon. There were so many webinars which were going on. And we could ask surgeons all across globe, like for Maharashtra Ophthalmological Society, we took help of Steve Arshinoff, and he came and he delivered a lecture during our MOSCON. So from one side he was talking, and from other side Ronald Yu was the speaker. So that was an advantage, webinars. Then Orbis has come out with a cyber site. Cyber site lectures are always there and very interesting, and expert speakers all across globe, they teach you. So take help of those cyber site. For the surgeons who are not privileged, like African surgeons or Latin American surgeons, there is a project Orbis, which is a flying eye hospital. So surgeons from all across the globe, they travel to that particular country. There is a lecture room inside the aeroplane. There is an operation theater inside the aeroplane. The live surgery is relayed, and there is a direct question and answer session with the surgeon, and that is how it is taught. Another important advantage for newcomers is that simulator-based training. There is a stall by Help Me See. So they have come out with the simulation-based training for manual small incision cataract surgery. Initially, there used to be only few steps of simulation training. Now they have come out with complications of M6 also, and now they are coming with simulation for phacoemulsification also. And in fact, a study was conducted with the Help Me See and LV Prasad Eye Hospital. The students were exposed to simulator training, and then they were exposed to surgery, and their skill was far better than those students who were not priorly exposed to simulation training. So I think for newcomers, sky is the horizon. You have so many of the conferences. There are SSTC, TSTC, DSTC stalls are there. You can go there, have hands-on training. So all in all, as compared to 30 years ago or 40 years ago, what we were exposed, nowadays students have lot of exposure to new technology, and they should utilize it to the fullest extent, and so that they become a better surgeon. Thank you. And I would like to thank again AIOS for the opportunity. Thank you.